Well, good afternoon, everyone. It is my pleasure to be here today to share with you some information on isolated RV shock and a case that I came through recently. So I'll just start with a case that I encountered a few weeks ago. So I had this patient, 48 years old gentleman, who has dyslipidemia and non-smoker. He presented, actually was picked up from home with ongoing chest pain for about 3 hours. He was hypotensive. His blood pressure is 85/48. This is his ECG from the field. So we have a field STEMI program. They pick up the patient, and if we think this is a STEMI, they come directly to the cath lab. What's worth to highlight here is just you could see that there's slight ST elevation in the inferior lead with reciprocal depression. And if you look at the V1, you could appreciate there is also some slight ST elevation. So the patient was suspected to have inferior STEMI, and for that reason, the cath lab was activated and was brought directly to the cath lab. This is his angiogram. Okay, so radial approach, left main is short, but we could see that the left main is good. The LAD, we could see there's some disease in the distal end, and the circ seems to be dominant. And we can see here the LAD is fine. There is some disease at the apical segment, and there is some disease that you could appreciate in one of the OM in this view. But it's a dominant circ, and the dominant circ does not have any obstructive disease per se. And then we did this, and we found that it's a non-dominant RCA that is blocked. The patient is in shock. Commonly, I would walk away from those patients, but we'll discuss what happened later. So the question always comes when you're dealing with the patient that present with RV shock: can you manage them conservatively? IV fluid maybe will be doing the trick, and they can come around, fix whatever reversible cause present. But in cases like this with non-dominant RCA, it's always hard to do anything for them. You know, just it goes against every single teaching to do anything. But if the patient was not responsive and they still have ongoing chest pain and they're hypotensive, then you might consider doing anything. And is there room for mechanical circulatory support? So the trouble that was with isolated RV failure is the diagnosis itself. There are different definitions, and most of the definitions of diagnosing RV failure was driven in the LVAD group patient who's already on LVAD, and then they have an RV failure secondary to that, and that's become where the information about RV failure coming from. So commonly, to diagnose a patient that they have an RV failure, they need to have a reduced cardiac index of less than 2.2. On top of that, despite being on inotropic support, and on top of that, their CVB should be more than 10. Currently, the literature talks about more than 15, and their CVB to wedge pressure ratio is above 0.63. Again, this is the data in VAD. But Naveen Kapoor actually, over the last couple of years, led a group of people from Tufts and start to do specific studies and investigation of patients presented with RV failure and acute MI. And basically, he came up with the new definition that's a patient to be having RV failure sitting with MI, you need to have the cardiac filling pressure, which is the right atrial pressure over the wedge pressure ratio more than 0.86. And their pulsatility index, so the BA pulsatility index, the difference between systolic and diastolic BA pressure divided by the right atrial pressure is less than 0.1. The other things is the stroke, the RV stroke work index also should be less than 10 in those patients. So he came up with some criteria, but those are the things that people don't look at and trying to go for to identify isolated RV. So if you suspect that, then you need to look for it. But why patients do have isolated RV failure? There are three things that will lead to RV injury and eventually RV failure. Either you have a reduced preload, or there is a direct insult to the myocardium, or there is increased afterload. Reduced preload, commonly we see it with massive bleeding, patient would present with massive bleeding, or if there is something to prevent the RV from filling with the tamponade, if there is loss for the atrial kick. And direct insult to the myocardium coming mostly from acute myocardial infarction due to the blockage of the acute marginal branch. Myocarditis, Takotsubo, other things that will give you an isolated RV problem. But what we see commonly are secondary to the increased afterload. Patient who has an acute onset and acute increase in PA pressure, like in PE, or patient who is known to have pulmonary hypertension and it has been progressing leading to that. and secondary to left-sided heart failure. So any of those things or combined will lead to RV injury, and therefore you get a cardiogenic shock secondary to that. You know, the presentation, the common presentation, elevated GVB, clear lungs, and the patient will have basically evidence of right-sided heart failure. It's common to have this. But what's important to me is the hemodynamic parameters, because that's what we don't have a pointer. Yes, we have. So if you look at, it's hard to see. So basically the hemodynamic parameters that you have evidence of shock, you have a cardiac index less than 2.2, and you have the right atrial pressure more than 15. Those are things suggest that you have an RV failure. You can go further and do the RA pressure ratio to the wedge pressure, and if it's above 0.8, then you suspect RV failure. And all of those things together suggest directly toward this diagnosis. Based on echo, commonly we talk about TAPSI, so if TAPSI less than 1.6 centimeters, this is another thing you can look into. The treatment, you know, try to do treat the reversible cause, supportive. If it doesn't work, you could start with inotropic support, but if that doesn't work, then you should be considering mechanical circulatory support, which is where we're going to be focusing on. This beautiful algorithm and pathway was developed by Naveen Kapoor and his colleagues, just to show how you deal with those patients in specific. So if you think somebody is coming with an acute RV failure, isolated, then you need to confirm the diagnosis. You need to assess the LV because it's very important, and then try to find what reversible causes are present and try to treat them. So if the patient has PE, treat PE. If they have acute MI, RCA occluded or dominant circuit occluded, fix that. If a patient, despite treating the reversible cause, but remain extremely hypoxic in PE, for example, or they have refractory VT or VF and patient present with acute MI, then you should be considering ECMO for those patients. But if you didn't find those reversible causes and the patient still has RV failure, think of tamponade. If there is no evidence of tamponade, then you should do an invasive hemodynamic using Swan-Ganz or PA catheter. You acquire this, and based on it, you could optimize the treatment for the patient, add inotropic support, consider pulmonary vasodilator in patient with severe pulmonary hypertension. And you could, if a patient is intubated, you could adjust their ventilatory setting using a high beep or low beep, depending on what you think is going on. But if you've done all of that and your patient is not improving, then it comes, you need to sit down and think of what's possibly going on. So that's the time where you should be considering inotropic support. If it's not working, then you should be talking to your team, the heart team with the surgeon, to consider mechanical circulatory support. And that decision, which device or system you're going to use, it will depend first if you think you need to oxygenate the patient. If the patient is hypoxic, right away you could consider them for ECMO. Easy. You could consider a tandem heart, because tandem heart has the ability to add to it an oxygenator, but tandem heart is demanding and not available in every lab, so ECMO is easily accessible in this situation. But if you don't think that there is a need for oxygenation, the patient's coming with the RV failure purely, the lungs is clean, there's no issue there, then you could consider an RV Impella or RA Impella, or you could consider the tandem heart. If despite what you've done, things are not improving, then you might be having an issue with the LV, and now you're having a biventricular failure rather than an RV failure. And the situation here, you need an LV support in this situation. It is very important, it was mentioned in previous presentation, that the higher dose of inotropic or more than one inotropic support actually is not a good sign. The higher you go on your dose, or if you add another one, the mortality increase in those patients. So you should be considering adding a different support to the patient if you start escalating therapy in RV failure. What devices do we have? We have a couple of devices: direct RV bypass or indirect, which is the ECMO in this case. Impella RB, which is the easiest to insert, the easiest to put in, is catheter-based percutaneous fast system. Is the pump itself is 22 French, therefore you have to have 22 French sheath first to insert this, but the catheter itself is an 11 French catheter. They give you flow up to 4 liter, and duration is up to 14 days. And it basically sucks from the IVC and pumps it out in the pulmonary artery. The recovery rate study, basically, they put an umbrella in patient post-VAD or post-cardiotomy or myocardial infarction. And what they've noticed right away, there is a drop in the need for inotropic support. And also at 30 days, total of all the patients in two group, about 73% were surviving. We're not going to talk about the insertion step because of the time. Tandem heart, basically, it's the old system is two catheters from two venous system, one in the RA, one in the BA, and basically one inflow, one another flow. The new system is, which is better, is Protect U, which is basically a single catheter. It's a huge, a 29 French, but the catheter itself has a proximal port to suck the blood and a distal port that is placed in the BA, as you can see here, that push the blood. It's 29 French, can be bought through the IJ, and you could go to the 31 French system. ECMO, we're not going to go into details for ECMO, but we know ECMO, we've dealt with ECMO in general. So if you end up, patient has in both RV and LV failure, then you need to consider two systems in those situations. First system is bimbella. So a right umbrella and a left side umbrella. And those are the easiest to insert if you have them, and they can provide you with a very good support. Tandem, basically, umbrella on the left side and tandem heart on the right side. It's more demanding, and I think the bimbella is much better option in this situation. And ECMO, which is more easily applied in those situations if you need the biventricular support. This is the algorithm we talked about. And I have just a few minutes to finish because I want to finish quickly here. So the conclusion is that treat them early, inotropic support. If they don't improve, think of mechanical support if you need it. Think of the LV if they need it. So I want to go back to the case, and here's something that's happened. So this is after we just ballooned the patient, the lesion. We saw a big arginal branch. We thought here just to walk away, we should have done that. We did not. I talked with my colleagues, and one of my colleagues is like, this is the cause of his problem. He's hypotensive. We should consider fixing this, even though it's a big guy. He's a very big guy. We should consider put a stent. We put a stent there. This is the result. But we had the sluggish flow on the RV, so we post dilated. And after we post dilated here, this is what we got. So as my heart was sinking when I saw that, to be honest, because first of all, this after we opened it, we should walked away. We didn't. Now we're trying to fix this. We end up with a bigger problem. The size is 2.5. Okay, and we both dilated with 2.75 and just distal in proximity. But when I think it was fragile heart to start with. Anyway, when I saw that, my heart was sinking, my soul was leaving. But, the hardest things about those things is, when you start dealing with those cases, you need to just focus, go down an algorithm they have. So I called my colleague who was outside, called the echo, cardiac surgeon. We just started to prepare. So I directly took a 3.0 cover stent right away into there. And I went there and I put that. What you can see, there's a lot of staining of the RV wall. And there is definitely effuging starting to happen. And this is the second picture after we did that. So now, not only that we put a cover stent, but we actually created the fistula. There was actually flowing into the RV, of the contrast into the RV. We covered most of the perforation, but now we opened into the RV itself for some reason. Given this situation, the patient RV was not very good and he was not doing well. But until now, the patient, there was no much fluid accumulating around that. So unfortunately, I took too many slides, but this, before this, let's go with this. Yes.
How it go to the RV? How the fistula go to
one of the times the wire was, when we were doing this, the wire was going in and out into outside and also into the RV itself. So how did the communication start? I don't know, to be honest. I wasn't expecting, and I was expecting with the cover stent things will resolve unless the perforation was basically not covered.
Yes. I think all what we see in this view is hematoma, whatever contained by whatever adventitia pericardial contained in the arm and the
Can you put the slides again?
RARV
Put
group.
the slide back.
Yeah. So I'll
It's
just
labeled.
finish here, then we'll discuss this just for the sake of time. So basically, I went right away with a ping pong and I decided to occlude the artery completely. So we talked today about fat embolization, but I use it in a different way, and I'll show you how we do it. So after you take the fat, you take it from the femoral side. You take a good chunk of fat and you cut a piece that is suitable, and you soak it in contrast so you could see it and it could just go easily. And then what I do, I load it into an export catheter on the outpost of the export catheter, while maintaining a little bit of negative pressure with a saline catheter, saline syringe, not air. You have a syringe with saline. So you maintain a little bit of negative pressure and you load it with the, if you try to load it with the wire, you keep going through it. You need to load it with the dilator. And then you inject it. And after you inject it, basically you take a picture. So this picture was 1 minute right away after that. And this is about 20 minutes after that. So we occlude the artery back again. We already bought a big tail catheter and we drain about 200 cc, no further things. Patient situation, we didn't need to intubate the patient. Patient didn't need to go for surgery. We managed to control all the situation in that situation. This is unfortunate complication that happen in a situation where you could just walked away, but sometimes you make decision in the situation where you think you could give a patient best benefit, but it fires back. I think the issue is not it firing back. This issue you have to know how to handle it in that situation, because those things happen every single day. And I think those things that you learn from and wear it as a badge of honor rather than hide and shy, be ashamed of it. I think that's the situation, even though it's an RV shock, but the turn of event was a bit different. So I thought I had to share this case with you. Thank you.